Next, I invite Dr. Natasha Radhakrishnan. She will be presenting yet another case of retinal vasculitis, but with a different etiology.
Good morning to all. It's good to be in the main hall with uveitis, which is a welcome change in KSOS Drishti. I will be presenting a 36-year-old male with right eye flashes and floaters, with no history of fever or joint pain. Vision was 6/6/N6. Intraocular pressure was normal. Anterior segment was within normal limits except for anterior vitreous cells. And the right eye showed patchy venous vasculitis along the inferior arcade with a few round yellow patches and hemorrhages and venous vasculitis elsewhere as well. The fluorescein angiogram showed right eye with slow filling infrotemporally and supratemporally with perivascular leakage, mild decrease in perfusion in the later frames with a mild disc leak, no other areas of vasculitis. Left eye there was no vasculitis or disc leak, and the OCT was normal in both eyes. Patient was started on topical steroids and cycloplegics, and 1 week later vision dropped to 6/9. Pulmo consultation was sought to rule out sarcoid TB, and the blood tests were sent. These are the blood tests which most of it just came out negative. And patient was also started on oral steroids, 60 milligram. And the pulmonology came back as IgM positive for aspergillus, for which the pulmonologist started on itraconazole. For us, what looked like those yellowish retinitis patches were not visible on the fluorescein, so I was not able to distinguish what kind of patch they were. And that appeared to be resolving with some patchy sheathing of the vessels, and the hemorrhages were persisting. So on the cover of itraconazole, the oral steroids were tapered and stopped, and the 6/9 improved to 6/6. But after stopping the oral and topical steroids in 1 month, he came back with a very similar looking picture with multiple hemorrhages and more active vasculitis. And again, those few yellowish round lesions infronasal to the disc. And the hemorrhages started increasing in the temporal periphery. Vision was at 6/6 parts. So it was a recurrence when the steroids were stopped. In the meantime, I restarted oral steroid and sent the patient back to the pulmonologist and discussed with him whether this aspergillus is actually relevant or not. He had refused a PET CT earlier, and so this time he underwent a PET CT, and a variable hypermetabolic small prominent lymph nodes were found, and they decided that it looked like a granulomatous disease. The repeat fluorescein showed this time more in favor of sarcoid, and the aspergillus apparently sometimes comes out positive in these bronchoalveolar testing. And I repeated the fluorescein because the vasculitis looked much more extensive than before, and you can see that now more posterior pole vessels are involved, and there is significant CNP areas also in the area of the vasculitis. With a systemic diagnosis of sarcoidosis, we stepped up oral steroids, and the pulmonologist added immunosuppression at MMF. And I did a sectoral PRP to the area of the right eye in the non-perfused area. And a repeat PET was done, which showed the lung nodules decreasing in size. The oral steroids were tapered, and patient was put on maintenance. And the patient is doing well with minimal coarse vitreous floaters, and the lasered areas are stable. There is no active vasculitis in either eye. This is the OCT at last follow-up with just a minimal epiretinal membrane. He continues to maintain best corrected visual acuity of 6/6, and he is continuing the immunosuppression. So like the previous case, I just wanted to highlight that many times what you get in your investigation is probably a red herring, and a non-response to treatment or recurrence on treatment should alert us that we are looking at some other diagnosis. And in any time in a uveitis treatment, you should be prepared to revise your diagnosis on the way. And here what saved the day was me picking up the phone and calling the pulmonologist and asking him, how relevant is that aspergillus in your lung? And I don't seem to have it in the eye. And so both systemic and local treatment should go hand in hand. Thank you.
Thank you, Dr. Natasha. Daily we see lots of vasculitis patients. Some are like occlusive vasculitis, some are autoimmune related, some are TB, sarcoidosis, some will be like post fever. So can you give some tips? Yeah, to Dr. Archana.
So basically, you start from the basics. You need to take a thorough history from the patient before you plan your investigations and then basically putting the puzzle together. So first of all is thorough history, thorough examination, and see the patient as a whole rather than just the eye. So see the patient as a whole, and again, don't hesitate to get input from physicians, and you rightly did that, Natasha. And they can help with, adding investigations, etc. The third thing, these are just, general things. I'm not going to delve deep into stuff, but the third thing is, before interpreting or even ordering the investigations, you need to be aware of the sensitivity, specificity, predictive values, etc., which I'll be covering in my talk. So if you look at the predictive value of the positive aspergillus in this test, it probably is very low. Therefore, you need to consider a different diagnosis. And again, lastly, but not the least, phenotypic recognition of the entity, and then try to see which condition we are dealing with. For example, birdshot chorioretinopathy, you can have associated vasculitis, but usually you do not get the macular edema. Sorry, the other way around. So vasculitis with no macular edema, you should be considering even lymphoma in those kind of patients. So pattern recognition and aiding diagnosis with pertinent points from history, systemic examination, and relevant investigations. There's no easy answer. There isn't any, there is no textbook cases when it comes to real world.
Yeah, when the pattern, with the pattern recognition, I was quite clear that this is probably not aspergillus in the eye. Correct. But with systemic aspergillus being treated, to put the patient on a full immunosuppression would may have disastrous consequences. So I was hesitant and just stayed with the steroid for a while.
Yeah, thank you.
So like I was saying in the first vasculitis case, I recommend you do ICG along with FFA. I think that's something that might have helped you in picking up the underlying choroidal lesion. Yeah. Was serum ACE done in the first?
It was normal.
It was normal.
Continues to be normal.
Yeah. There again, it's not a very sensitive or specific. Yeah, that's all. And you really need to learn how to separate the wheat from the chaff. That comes with experience. Yeah.